I'm very pleased to introduce Dr. Ronald Jackups today from Washington University in St. Louis. He holds several roles there. He's the Associate CMIO of Lab Informatics at Barnes-Jewish Medical Center, as well as the Program Director of their Clinical Informatics Fellowship. And he's Medical Director or Co-Medical Director of 3 additional labs there, so wearing a lot of hats. In addition, he has a wide research background surrounding not only his clinical practice in transfusion medicine, but across various aspects of medical informatics and pathology informatics. And I was introduced to Dr. Jackups through his work with the Association of Pathology Informatics, where he's also held numerous roles and is currently the Training and Education Committee co-chair. So we are thrilled to have him come talk today. And with that, I'll turn it over to you, Dr. Jackups. We really appreciate your being here nice and early.
Yes, thank you. Thank you very much, Dr. Stoffel, for that introduction. And thank you also for the invitation and opportunity to speak about a topic that I'm really passionate about, which is clinical decision support for lab medicine. So I have no disclosures, and the learning objectives for today are to define clinical decision support, identify lab processes that could be improved by clinical decision support, which I'm going to refer to as CDS for the rest of the talk, and then to design CDS interventions that improve care while avoiding unintended consequences. And if you have questions at any time, please put them in the chat or raise your hand. I'm happy to have this be an interactive discussion. So I always start with my CDS talks with something completely unrelated to medicine, which is petrified wood. And you'll hopefully understand why I'm doing this by the end of the talk. So the Petrified Wood National Park is in Arizona. I have never been there, but I assume it's quite a beautiful place with a lot of obviously petrified wood on the premises, which is part of the problem. So some of this wood is loose and visitors frequently remove it. So to attempt to prevent people from removing it, the park put up signs which increasingly became aggressive in their tone, with statements like this: "Your heritage is being vandalized every day by theft losses of petrified wood, mostly a small piece at a time." And the result of this was actually that theft increased. So this unintuitive result makes a little more sense if you think rationally that the message of the sign was to say that stealing petrified wood is a common and socially acceptable behavior. Or another way to say it is, all this wood is being taken away. You may as well get yours while you still have the chance. And so you can see how well-meaning messages can sometimes be misconstrued or cause unintended consequences. And as we talk about CDS, we're going to talk a lot about messages causing unintended consequences. Let's now think of or talk about a good example of messaging, which was an anti-littering campaign in the 80s in Texas. The problem, of course, was a high rate of littering on state highways. And I don't know if any of you know where I'm going with this, but a very famous motto came out of this, which is "Don't mess with Texas." Simple, brief message put up on signs across the highway. And as a result, littering decreased by 72% over 4 years. So a very successful campaign based on a very simple motto, which of course is now ingrained in American culture. And this demonstrates that short, direct messages that invoke social norms can successfully change behavior. So you see the good and the bad of what messages can do, and that is a key part of what clinical decision support is. So CDS is the use of information and communication technologies to bring relevant knowledge to bear on the healthcare and well-being of a patient. And the examples I provided, really, I want to stress that this isn't an IT issue. This is really a combination of information and communication, and how we communicate with providers is just as important as the goal of whatever we're trying to fix. So being good at CDS requires expertise in several aspects of clinical informatics, including, of course, evidence-based medicine, which generates the the objectives, the goals that we want to inform people of. Also, we get to be armchair psychologists in a way, trying to understand how clinicians make decisions, why they make them, and how we can affect those decisions in a positive way. Of course, informatics does matter here, so we need to be knowledgeable in the way our health information technology is built, and since most of the decisions we tend to want to affect in laboratory practice are ordering of lab tests or blood products, we have to be knowledgeable in the CPOE, which is the computerized provider order entry system. And then finally, we have to be we have to understand how humans interact with computers, so that we understand how we get to humans, how we convince them of the right thing without frustrating them or making their work harder, which can sometimes have the opposite effect that we desire. So when I say CDS, most people jump to order alerts or some kind of pop-up as the prime example of CDS. That is an example of CDS, but my experience has been that alerts fail more often than they succeed. And I like to hold alerts off as the last resort to fix whatever the problem is that I'm working on. So it's much better to have a full perspective of CDS, to know what kind of options you can choose to address the problems you're trying to fix. So that can include the way you build orders using search menus or templates, the way you put orders together in things like order sets and order reflexes, and then yes, of course, order alerts, and we'll talk about all of these things with examples coming up. And then outside of the actual order process, there are several opportunities for education, both before the decision is made and after the decision is made. So you can do reporting, benchmarks, but then you can also take the information of how people have used orders, bring it back to them as a way to get them to understand what their current practice is and what it could be. And I'll provide examples of that later. And then more still future looking is the use of machine learning and artificial intelligence to create complex diagnostic algorithms that are difficult for a provider to work through on a patient by patient basis in a busy practice. So instead, automating a lot of those decision processes, but ultimately giving the final authority over the decision to the provider. All right, so we'll start with a few examples. The first being order sets, and I spent really months of my career on COVID after the pandemic started, and I had to put a lot of my clinical roles to the side and focus not on validating the test. I'm not a microbiologist or a virologist, so I had nothing to do with actually creating or validating the test. My job was to make sure that people used the test effectively, and that even more importantly, that we didn't run out of test kits, which we were quite frequently afraid would happen because of the supplies. So the problem here is that we had several options for providers to choose from, including the standalone COVID test, what we now call the 4-in-1, which is 4 viruses in one panel, and then a longer panel of 12 or 13 tests. All of these having a certain amount of throughput and a certain amount of supply that we have had to be careful about. But also importantly, they had different indications. So some patients, particularly symptomatic patients, might benefit from testing for influenza at the same time that you're testing for COVID, whereas asymptomatic patients who are just need clearance of COVID before a surgery do not need as extensive of a test profile. And so instead of just leaving it up to the doctors, who sometimes know the right test, but sometimes they're inexperienced or they don't realize that we could be running out of tests, why don't we start with asking the provider, what is the patient's indication for testing? And then from that, guide them to what we feel is the best test, not only for that patient, but for the system as a whole. So, so you can do that with order sets or order panels. This is an order panel. And if you haven't figured out, I am using Epic. I have no love or hate of Epic, so I'm not endorsing one way or the other, but this is what we do at our, this is what we have at our institution. And so you can, for the panels, you can design them. Instead of starting with the test name, you can start with why do you want to do this test? And then as they pick and choose, you lead them to what the best options are. All right. Now within the order itself, you also have a lot of opportunities to communicate with the provider. And so you can do that using order questions. One very common order question to put in to an order that could be misused or not ordered appropriately by an inexperienced clinician is the indication. So, this test or this blood product is often used inappropriately, or we're worried about overuse. So please tell us why you're doing this. It has a couple benefits, which is number one, if the provider's intended use for this order is not on the list, it might cause them to reconsider or at least think more in the future about why they're using either the test or the blood product. And if this isn't obvious, this is for a red cell transfusion order. And then the other nice benefit is that these selections can be recorded. And so we have data on every blood product that has been transfused at our hospital. We know at least what the provider said is the reason that they're transfusing, and that helps us track patterns. If one indication grows, or if we find that, for example, a regular general medicine floor is picking hemorrhagic shock on every one of their patients, well, it's clear they're just picking the first answer and just trying to get through it without thinking, through the process. And so we can use that for targeted interventions. We can also, I actually use this to drive alerts, which I'll talk about in a second. For example, if you select hemoglobin less than 7, but the patient's most recent hemoglobin is greater than 7, it actually triggers the alert that says, did you know that this is not actually correct? And maybe you should go back and think about your indication. So this wasn't at WashU, this is at Hopkins, but I find it to be such a fascinating example of a different part. So instead of targeting them, providers at the order stage, target them at the feedback stage. And it's a little difficult to understand what's going on here, but basically they aligned all of their surgeons and anesthesiologists who transfuse blood intraoperatively, and they looked at all of the patients that they transfused and averaged them together. And for each of the surgeons or each of the providers, they've found out the average trigger is what they call it, which is the hemoglobin before their first intra-op transfusion. That's the beginning of the red line. And then the target, the hemoglobin after their last intra-op transfusion, is the end of this red line. And they aligned those ranges among all of the surgeons and all of the anesthesiologists to compare which surgeons are more restrictive in the way they use blood, and which ones, which would be up here, and which ones are more liberal, targeting much higher hemoglobins. So, and this is nice, and for the purposes of the publication, they de-identified all the providers, but in reality, this Steve Frank did this, and he explained to me that they did not de-identify at the hospital, and they instead put all of these names in the bathroom stalls in the physician restrooms, so that the surgeons could compare to one another. And the idea there is to give a little bit of friendly peer pressure to convince surgeons, well, my peers, the people who do the same surgeries I do, are more restrictive and they're having just as good outcomes. So maybe I should try to get up. I should try to move up on this list. Conceptually a nice thing to do to nudge people in the right direction. But we probably couldn't get away with this at my institution. I think the surgeons would run me out of town. Okay, so those are examples of order stage, CDS, as well as feedback. I do have to talk about order alerts, but I always leave that to the end of my list of examples. Again, because I think these should be matters of last resort. So order alerts, or sometimes called best practice advisory, and that's particularly Epic speak. So if I lapse and I say BPA, that's what I mean, an order alert. These are messages that appear in the CPOE in response to an order provider's behavior and designed to direct or redirect that behavior. So they come in several flavors, and the first way to split them up is into non-interruptive and interruptive. So non-interruptive are the ones that show up but don't get in the way of the provider. They can be completely ignored. So they're on the screen somewhere, and the provider can see them, can read them, but doesn't have to do anything to continue with their workflow. And those are, easy to build. They're not, obstructive or intrusive, but they tend not to work very well because providers aren't looking around as much to find this information. What we tend to focus on are the interruptive alerts, the pop-ups, which prevent further action in the provider's workflow unless something is addressed. And those can be further subdivided into soft stops and hard stops. And the definition for these terms, I will say, is not universal. My experience has been what I'm listing here is the most common agreed upon definition. But I also feel that it explains pretty well what these two things are doing. So a soft stop is an interruptive alert that can be bypassed by the provider if they do something, which could be clicking a button, acknowledging that the message was received, whether they listen to it or not, but they can proceed within their current channel. So if they're in the order, they ordered a test and you get a pop-up that says, maybe don't order this, the provider can say, thanks, but I'm not going to listen. I'm going to order it anyway. A soft stop will allow you to do that without any other problem other than clicking on that window. Hard stop, on the other hand, is much more aggressive. It will stop the provider within the channel that they're working in. There's no way to get past it in the electronic space. So if you get a hard stop, oftentimes if it's going to be bypassed at all, it'd have to be bypassed, for example, with a phone call to the laboratory. So these, as you can imagine, are much more obstructive. and much more obvious and frustrating to providers. So they should be used very sparingly and with a very clear bypass process defined. And of course, only for the very high strategic level concepts, which would be things that are life-threatening. So for example, in pharmacy, putting an extra zero at the end of your dose could be life-threatening to the patient. And that would be a really good time to have a hard stop. And I'll talk more about hard stops, which are, have, very positive effects on dropping the bad behavior, but can also have very negative effects, both with unintended consequences as well as losing the goodwill of the providers that you're trying to convince to improve their care. All right, this is an example of a soft stop, only to show some of the elements that I think are necessary, or at least very important elements of an effective stop. The first thing is you need objective data, and specifically patient or patient-specific data. So in this example, this is an alert for duplicate orders of CBC within 24 hours. So it says the patient has already had a CBC ordered, and it's pending collection, so you don't need to order another one. Then it has a statement of best practices, and this is short. You want it to be short but also clear. And this is a statement that daily labs are not recommended anymore, even as a link to the to a paper if you want to go out and look there. And I should say this is not an Epic alert. This is pre-Epic, something that we built. And then finally, as I said, you need something that the provider can do, because if it's just click a button and you're done, it is so tempting for the provider to just click it and move on. Whereas if you force them to answer something, you can make them stop and think for a second, as well as potentially get information back from them. So this is, if you want to do CBCs twice in a day, just explain to us why, and then you can move on. Okay. So back to Epic. This is one example of a soft stop for duplicate order alerts or order checking at our hospital. So very simple statement of best practice. This patient already has a ferritin level ordered in the last 12 weeks. So this is to try to get people not to order so many ferritins. There's the direct information about the patient. So this test was collected yesterday. Here's the result. You don't even have to go into the lab section to see the result. And it's sort of recommended. Here's the button, do not order, but it's very easy for the provider to move on. So there is an acknowledgement, but it's not a statement. So this is a simple duplicate check. It does actually work pretty frequently, but it doesn't have any complex logic behind it. Slightly more complex are these two alerts, which are both for C. difficile testing, which is a high strategic target, at least at our hospital, and I'll explain why in a second. But these are a little more complex because it is not just ordering a test within a certain amount of time of another test, but also based on the result. So if a lot of research has shown that if the C. difficile result was negative, that there's little value to repeat that testing within 4 days or 96 hours. And if the previous test is positive, there's little use to repeat that in 10 days because this test should not be used as a test of cure to prove cure. So we fire either of these alerts. It has a statement of why repeat testing is not indicated in this patient. Again, it gives the provider an option to remove or keep. You can see that it's defaulted as remove. If they click keep, then they have to also provide an acknowledged reason. So there are a couple more clicks. That tends to put a little more blockers in the way of the provider, and give them the opportunity to think a little bit more about this. That's nice, but this still gets bypassed pretty frequently. As I said, soft stops are easy to bypass within the provider's channel. So literally today, in about 2 hours, we're going live with this. And I don't know if it's going to be like the best thing ever or the worst thing ever. It's probably going to be somewhere in the middle. But we are changing our soft stop to hard stop for C. diff. And we're adding a couple things. So the first thing, we're putting previous testing on the side. This is, you could call this non-interruptive. The provider doesn't have to look at it, but it's a very helpful way to show the results. And then if one of those rules I mentioned in the last slide gets triggered, then you get this order question. So it's no longer a pop-up alert. It's a sneaky kind of thing that a few other institutions have done as well. So we're copying this, and I'm hoping we're going to have the same results. Basically, it has the same statement. And in this case, if you want to proceed, you have to give a passcode, and it has to be the right passcode. You can't just put in a blob and then click OK, because if you do, you'll get this. You'll get this message. And this is truly the end of the line. This is the hard stop. So you cannot proceed within the order pathway anymore. You have to call the lab. The lab will give you the passcode, and then you can enter it. In this first stage, we have instructed the lab not to push back or debate why they want to do this, just to give it. And the ultimate goal here, or the reasoning behind that, is that the barrier of having to stop what you're doing, call the lab, and then enter the passcode is enough to prevent providers who really have minimal reason to do this test and are just locked in their mind to do it. And that has been seen at many institutions. This is not the same thing. This is still a overall duplicate test check that was at Cleveland Clinic, but it showed pretty clearly that hard stops are much more successful than soft stops when built appropriately. But as you could tell, it's aggressive, and it has a way of frustrating the providers in a way that can cause both unintended consequences, which it might prevent an order that really needed to happen, or at the very least can blow back in your face and cause a lot of frustration that bubbles up, and then you lose goodwill for your next effort. Michele, you have a question?
Oh yeah. For your last slide, I'm curious whether like a future phase will include asking the providers to put the reasoning for why they want it. Is that kind of where it's going next?
Yeah, no, I think that's a great answer, or a great idea. And these and it does highlight the fact that this is quality improvement. Quality improvement tends to be cyclic. These are the PDSA cycles, which I won't describe, but each iteration we monitor what worked, what didn't work, and then we can add things. I think that's a great idea, and it's combining something I had mentioned earlier with this, and that could provide a little bit help as we see what happens. My first step is to see are people actually going to bother getting the passcode, because if everybody just gives up, then I'd say we're done for the day. But yeah, no, I actually think that's a great idea. Actually, our next phase is to incorporate patients on laxatives, which I think is going to cause a lot of frustration. And so an order question where they give an opportunity to explain themselves might soften the blow, might help them feel that they have some ownership over the process. So that's a great idea. So this was, as I said, this is Cleveland Clinic's version. We did our own version at BJH at our hospital, Barnes-Jewish Hospital, and we saw that it was being ignored. You know, honestly about the same as was found at Cleveland Clinic, even though there are differences between the way we built these. But what I was really interested in is not whether it would work, but why it works or why it doesn't work. So we looked at the different tests that we had put on this duplicate check. You can see there's variation in the compliance rate, compliance being that the provider canceled orders. But what I found really interesting, and we did publish this, was that the compliance rate differed by provider role. And so you could see the highest compliance, the highest rate of listening to the recommendation came from attending physicians. Just below that, this says physician. These are residents and fellows. Then nurse practitioners in green, and then way at the bottom are registered nurses. And you know, again, this is where we put our we become psychologists. Why does this make sense? And I think it does, because what you're seeing is the people with the most power over the decisions that they're making, the people most responsible for the decisions, are most likely to stop, read the directions and follow them. Whereas down here, the RNs feel pressured to put in an order because a doctor told them to. And they are not, you know, in their very busy process, they don't have time to stop, call the resident or call the attending and say, I got this alert, can you evaluate it for me? They're not going to do that. They're going to push through. No fault on them. And honestly, I don't think an RN should be responsible for placing orders except in, you know, extreme cases. But we've developed this process, and that brings a new challenge to us, at least in academic hospitals, which is you need to target the person who is making the decision as closely as possible, or it's not going to be as successful. To this point, oh yeah, Michele, you got a question?
Oh, sorry. I was just curious whether is that, you know, months corresponding to January, February, and is that,
oh
like
yeah,
that big spike is because of July and the new residents?
Yeah, I forgot to mention that. Thanks for pointing that out. Yeah, you can see it was cyclic. We did it over the months just to see, you know, to test my hypothesis that things would be different in July when new attendings and new residents come, and it is. So they're actually more likely to listen at the beginning when they're still naive and they haven't developed all the workarounds, and then later in the spring they finally figured out how to bypass things and they go to it. That's the sort of cynical answer, but the other potential positive answer is that they figured out what they're going to get an alert for and what they aren't, and they stopped doing the bad behavior, so they don't even see the alert. So you can balance what that is, but we found that to be an interesting pattern. So yeah, you can design what you think is the right way to do things, but workarounds are very common, and if you don't provide if you really haven't optimized the process for the provider, they will find workarounds. If you try to fix it by putting in blockers, they will still find workarounds. They will find some other way to get around that blocker. And actually, as I was walking into work today, one of the sidewalks that I use has a sign that says sidewalk closed, but it's not really closed. There's nothing avoiding you from getting on it. And the area of grass right around that sign is already beaten down after a week. There's like the grass is clearing just as you see here. And it was just a reminder to me that people will find workarounds. You can't stop their workflow unless they understand why it's important to you. And that again gets back into the psychological aspects of it. So this is a well-known theory about how people make decisions. And we like to think that we as doctors are generally reflective people, that we take a second, we are rational, analytical, and we make our decisions based on the expected outcomes, like evidence-based medicine would suggest, and that we do risk-benefit analysis for taking into account all of the possible outcomes that could result for a decision on a patient. But in reality, we only do this for rare decisions where they're complex and we have to put effort into them. The reality is that most providers do not have time to reflect on most of the decisions they're making, and they flip to their automatic brain, which is quick, not enough time to make all the calculations, to analyze it, potentially error prone, but has the benefit of just getting decisions out, getting them done. And these people tend to focus on cognitive heuristics, which are simple subjective assessments of risk. You can call them rules of thumb. We know them, even if we don't give them a name. We tend to use them ourselves. Everyone, I hope, is familiar with Occam's razor, which is, don't overcomplicate your diagnosis. Think of the simplest diagnosis first. There's also something called Sutton's Law, which is start with the most obvious diagnosis, avoid, the zebra. And essentially the understanding that an unlikely presentation of a common disease is more likely than the classic presentation of a rare disease. And it's something that attendings remind their residents on a frequent basis, and eventually they figure it out. Then it goes into their automatic brain and they stop thinking about it. Like I said, it has benefits for workflow, but sometimes can be error prone. And when that happens, we call that a cognitive bias, which is a counterproductive reliance on a misleading heuristic. We know these examples, but these actually have a name. So the first, there's several of these. I'm just going to list out the three that I encounter a lot. First of all, representativeness. So this patient has the pentad of TTP, so it has to be TTP. It can't be anything else. And then they pursue that direction without thinking of the patient's entire history and context. That's the representativeness, looking for the classic signs. Availability, which is making decisions based on prior experiences, which is a good thing unless the experiences are so vivid that they cloud your judgment. So I made a decision and the patient had a bad outcome. I'm never going to make that decision again. That sort of doesn't make sense when you stop and think about it, but it is very common. I'm afraid of hurting another patient with that decision, so I'm just not going to do it again. Anchoring is also very common. That's your gut is always right, which is not true. I play bar trivia a lot, and my gut is frequently wrong. The first answer I write down, and then I'll cross it out and put the right one later. Don't always trust your gut. Don't always stick to the initial impression. Look at all the information you can get, do test, initial screening tests, and then use that to guide your judgment. That's more of a rational process, but that tends to be the more successful one, but people can get stuck in ruts. So how do you pull them out of this? You need to design your CDS interventions effectively. And there are two well-known rule books to do this. There are others, and there's a lot of good literature on why CDS interventions succeed or fail. But the first oldest one is called the 5 Rights of CDS. Make sure that you provide the right information. Those are the messages that I was putting in those alerts I'd shown to the right person. As I said, you want to get as close to the decision maker as possible. If you hit the RN, that's not going to do, that is much less likely to be successful. In the right CDS intervention format, as I said, you want to be careful about using alerts. Try something less aggressive at first, and if that fails, then move on to something more aggressive through the right channel. You know, for most of what we're doing, we're talking about the CPOE. That's the channel, the order process at the right time in the workflow. In general, the closer you are to the point of order, the point of where the decision is made, which for us is usually when the order is being placed, that tends to be the most successful. The farther out you get, the less people remember or reflect on the information given, and the more they just use their automatic brain. In more detail is something called the 10 Commandments for effective CDS, and this is developed over experience with a lot of different CDS interventions in the literature. You can see a lot of these are focused on affecting the automatic brain. Do things quickly, little things make a difference, fit into the user's workflow so that they don't have to stop and reflect because they don't have time to. Simple, keep things simple. Ask for additional information only when you really need it in order to, to help you design these. But the most important here that I highlighted is monitor impact, get feedback, and respond. This is very difficult for us because often we don't necessarily, we're not the ones that have actually built the CDS. We help design it and the conceptual framework of it, but we're not the ones building it. The resources go into building it, but those resources tend to stop once it's built. The people who make it, they build it, here's your alert, we're done. They walk away. And then you're left not knowing if the alert ever worked or not. So it is critical for us to have access to data within the system so that we can pull information on how often the alert activated and how people responded to it, the indications they selected if we gave them that option, because then that informs, do we like this alert? Do we want to keep it or keep it the way it is? Or do we need to change it? Or was it a failure and we just need to get rid of it and think of something else? If you are not doing that, you have no idea if it worked, and you could actually be making things worse with the process. So in order to do this monitoring, you have to first think about what are you measuring? And in quality measures, we tend to break those into outcome and process. Outcome is the final result, of course. So this could be cost savings. This could be some kind of patient care metric like mortality. But the problem with these is that they may not be sensitive enough to detect the results of one small CDS alert in one aspect of care. Process measures are looking at how people respond or how the process has changed. So if you give them an alert, are they listening to the alert? So that is, of course, much more direct, focused on the intervention, this one alert or CDS intervention. But it doesn't necessarily correlate to improvement in clinical outcome. So what you really need are both of these. You need to do a mix of measuring both outcome and process measures to prove that your interventions are doing something good. You also want to think about the study design. In practical, in all practical processes, the longitudinal study is most likely what you're going to end up doing because it's the least resource intensive. Basically, you put in an intervention and then you measure outcomes both before the intervention and after the intervention. Fairly easy to do as long as you have access to the data. But the problem with that is that, if other things were happening at the same time you made those interventions, you can't say for sure that the intervention was the cause of the good thing or the bad thing. So, there are some problems with how you interpret that data. Randomized study is better in the sense that it gets rid of most of the other causes of bias. So you can randomize one floor to receive an alert and the other floor not to receive the alert, and see how the two floors do. That sounds great, but as you might imagine, it's more resource intensive because you have to make sure the alerts go here, but not here. That is almost by definition a research study. But ironically, you're not consenting the patients, you're consenting the doctors. You're telling the doctors that you're going to do this. And once you do this, that causes what's called the Hawthorne effect, which is now the doctors know that they're being observed, and they may change their behavior based on that. So, they were on the floor with the alerts, and then they moved to the floor without the alerts, but they've learned that behavior and they've kind of applied it. So both studies have issues with them, but the reality is you're probably going to do a longitudinal study in most cases, just because that's what you have the resources to do. So this is an example of a process measure. This is a Stanford study looking at how CDS affects, can you use CDS to get people to transfuse less when the hemoglobin is above 8. And you can see when the intervention is put into place, there is a drop. But the other thing I think you can appreciate is it was already kind of going down before the alert was put into place. So how much of this was due to the alert versus some other kind of process like education? Hard to say. They also looked at outcome measures. So you notice mortality went down after they implemented the alert. Do I believe that this mortality is based entirely due to the alert? No, I don't. But it at least shows that mortality did not go up, that there weren't really bad unintended consequences. So putting those together tends to be a useful way to look at, useful way to monitor your interventions. What happens if you don't put in a good intervention? There are several unintended consequences. The most common one is what we call alert fatigue. Providers on the floor, we build this alert. Why aren't people listening to this alert? Well, it's because we only know about the one alert that we built. We don't realize that the providers on the floor are getting dozens or hundreds of alerts every day, having to respond to them. After a while, they stop listening to them. It's like crying wolf. That's what the image up there is. And so if you design several poorly designed alerts and put them all out there, not only will they not listen to those, but if you ever design a good alert, they may not listen to that because they've been trained to ignore alerts. So it can be worse to put in a bad alert than to use no alert at all. So you have to monitor frequency, response rate, and adapt accordingly. Ultimately, what you want to do is balance, just like you would with a test, with a lab test, sensitivity and specificity. So I want to maximize how often I get true positives, an alert that really targeted the right situation versus false alarms that people are going to ignore. On the other side is automation bias, which is over-reliance on alert messages. So another way that people can respond to alerts when they get 100 a day is to just accept every one because, I'm sure the recommendation is good. They wouldn't build it otherwise. That, again, triggers the automatic brain, leads to loss of integrated reasoning, and can even cause what this theoretical idea of risk compensation, which is that if you provide a safety net, people don't have to care about it as much, the process as much. So I don't know what dose to order for this patient, so I'm just going to pick what I think it is, and the system will tell me if I'm wrong. So that kind of expectation of a safety net can actually be just as dangerous. I include this as an example of a poorly designed alert, which is provably poorly designed, and I think it's important to talk about it. So EPIC has a model to predict whether a patient has sepsis, and if you have EPIC, you have probably been forced to address whether to use this or not because they really love this alert. The model itself is mostly proprietary, so we don't know exactly how they're aligning all the features. But the goal is you can use this alert to trigger, or sorry, this prediction to trigger alerts. So an example is like this one. It says patient might have sepsis, so do this, do this, do this. Okay. This is at the University of Michigan. They did a retrospective validation. So they did not, as I understand it, they didn't actually show the alert. They ran the alert in the background as a hidden, so that they know when it would have fired versus when it didn't. And they defined sepsis by CDC and ICD-10 definitions. This was their gold standard, which may or may not agree with Epic's standard. And well, it doesn't, obviously. So the ability of the Epic sepsis model to predict the gold standard sepsis was 0.63, which, if you know about ROC curves, that's really bad. 0.5 is random chance. And it's actually lower than the AUC that Epic advertises. So it says when you put this into the real world, it doesn't work as well as what Epic says it should in an ideal world. But when you look at the details, it gets much worse. So it identified very few patients who weren't already on antibiotics. It missed a lot of patients that should have been identified, and it found a lot of false positives, which would have caused unnecessary workup. So some of the reflections on this are these alerts really reflect the presence of sepsis already apparent to clinicians. So there really wasn't value added. Additionally, clinicians would have to evaluate 15 patients to identify a single patient where it would have helped. This is alert fatigue. And then finally, proprietary models are difficult to assess. This is the black box. So this is how things can go wrong. I can only blame Epic so much because you can't make an alert that's going to work in every institution. We really have to refine it site by site. So how do you leverage this automatic brain to get people to do what you think is appropriate? You can use the default heuristic, which usually involves pre-checking things on the orders. So instead of forcing an inexperienced clinician to imagine what the right answer is, why don't you give them what the right answer is 80% of the time and let them work through it? And then the other is, bandwagon effect. So provide a normative statement that providers can use to compare themselves to others. Ultimately, you want to make the right decision easy to choose and the wrong decision hard to choose. But as I say this, I want to inject a little humility, which is what I think is right is not necessarily right. I am a laboratorian. I'm not up on the floor. I'm not seeing the patient that the provider is seeing. So we have to give them an outlet to bypass the decision that I think is the right one on a grand scale and give them that opportunity to explain why. So this is one example of using the default heuristic. We were having problems with patients ordering 2 units instead of 1. So we took away the 2-unit button. We defaulted the 1-unit button. That doesn't mean that people couldn't order 2 or more units. It just meant that they had to go through a couple more steps. And then if they picked 2, we also provided this normative statement. We're in a pandemic. Please try to use 1 unit instead of 2. Pretty simple interventions. And it actually had a dramatic change in use of 2-unit orders and an increase in 1-unit orders. You can see this looks like rebound. That's actually just because we started doing surgeries again after the pandemic lightened up. But overall, the 2-unit to 1-unit ratio remained low. And for oncology, it was virtually wiped out. And that's because oncology is a very regimented, had very regimented processes. And once you get them to agree to change that process, it is very reliable. So this was really an area of great success. It didn't have as much change in the cardiac ICU, which I'm fine with because those patients are at higher risk of bleeding and they're more likely to use multi-unit transfusions. The BPA that I mentioned here, this did not fire very often, and it actually decreased over time, but we still had these durable changes, which to me suggests that that defaulting was much more of the successful intervention than the alert itself. So just to end, I will go back to that petrified wood example I gave and say that some psychologists did do a study where they randomized signs in different places of the park and baited the area with pieces of wood to see if people would steal it. This just almost makes me want to be a psychologist, but these are the messages. I'm going to read them very quickly, and then I want you to think about what you think the most successful response was. So please don't remove wood, remove the petrified wood from the park. Please leave petrified wood in the park. Many past visitors have removed wood from the park, changing the state of the forest. And the vast majority of past visitors have left the petrified wood in the park, preserving the natural state of the petrified forest. Normally I do a show of hands. It's hard to do on this, but I would say a lot of people pick answer 4. Answer 4 is number 2. The best answer is actually number 1, which is just don't do this. Please don't do this. And I think that this tends to work very well. Whereas I think number 4 probably works better with clinicians who want a little bit more explanation. But this don't do this is often very successful. We saw it with don't mess with Texas. We see it if you've ever looked up the Choosing Wisely recommendations for better use of resources. You see don't at the beginning of several of the recommendations. So these short and just short normative statements tend to be very successful. And we did this with our coag testing when we started running out of tubes. We just said, please do not order coag testing on a patient without a history of bleeding. And we also have a little duplicate check that says, please don't order this as a daily lab. And I thought these really wouldn't do anything at all, but they actually dropped utility by about 20%, which to me was shocking. I was shocked at how successful this was. So sometimes these very simple changes with very short messages can have very good effects. So to conclude, CDS is a powerful tool that can improve utilization of lab testing and blood product use. Careful development and monitoring is required to ensure that they meet their stated objectives, and poorly designed or unmonitored CDS can result in alert fatigue or other unintended consequences. So I'm sorry I ran almost up to the end, but thank you again for inviting me, and I'm happy to take some questions. So Dr. Khalifa, I see you have a question.
Well, thank you. I enjoyed this talk very much. It touches very, very sensitive points. I am an anatomic pathologist here. I admire your incorporation of psychology in this informatic related topic to highlight the fact that we cannot manage healthcare without understanding the psychology of our end users. That's a fundamental thing. I can't help but noticing that you probably deliberately didn't touch on the utility of CDS in surgical pathology or anatomic pathology, and I keep trying to guess why. Maybe because you found surgical pathologists are as very opinionated people. We are interpretive, so you cannot regulate our practice. I don't know, but I can see a lot of utilities here, either in the way we order special stains, in the way we formulate our reports. I always tell residents, start your report by +4 or -4, just like don't do this. Either in the messaging, when a pathologist puts a report and the language is confusing, can we put a stop to that and say, try to do this? So has there been any effort to apply CDS to anatomic pathology? Thank you again.
Yeah, thank you. And I'll say it wasn't deliberate. It is more, I'm CP only. My scope is lab medicine. But I would also say I have seen, to be honest, I don't think I've ever seen literature that really focus on the surgical pathologist's practice and using CDS to influence or improve the decisions that they make. And I don't think it is necessarily because they would be refractory to such interventions. I think all of us, I have to sometimes stop myself when I make these alerts and remind myself these are doctors, they're nurses, they want to do the right thing. When they bypass it, it's not because they want to spite me most of the time. They want to do the right thing. It's just they're too busy to stop and reflect on the decisions that they make. And so I really haven't thought about it, but I think the opportunity, you need to think about the channel. Where are you going to send these messages? And if your surgical pathology module that you're using is very rudimentary, it may not even allow the options of putting in, for your patient, maybe these are the stains you should select, or start with these stains, pre-check these stains, don't pre-check those stains. I don't know because I'm not in that space, but I think that is a wonderful idea. And I will mention it to our AP informaticist and see if there are such opportunities to do that. But that's fascinating. Yeah, thanks.
I was gonna say, we don't want to see like lists of IC utilization in our restrooms anytime soon.
that can be done. Maybe you don't want to see it, but yes, it can be done. Dr. Crossan?
Yeah, Dr. Jackups, thank you very much. I really enjoyed that. I have a question about adding educational material to the DCS activities. What do you find is the best way to do this? Do you always include a specific reference, or you just say the literature suggests? Do you give expanded educational statements or very brief educational statements?
Yeah, I think that is still mostly an art, which is my way of saying it's not well studied, and there's a lot of trial and error involved, but there's also a lot of preference. So I will, I hope this doesn't sound like a dig at my micro colleagues. The microbiologists in our team tend to want to explain more, and I'm the person who likes to explain less. and I don't dictate exactly what they say, because I'm not an expert in that space as much, and I'm willing to do trial and error. So to me, even if there was a good literature on saying in general how much you explain matters, I wouldn't necessarily listen to it, because each of these CDS interventions is so unique to our institution and to our workflow at the time that it's mostly trial and error. So what I usually do is I let people, if it's their alert, come up with a message, and they start with a message like this long, and I say, nobody's going to read this, so shorten it to this. But it also depends on the target. So if you're targeting busy clinicians who should know better, and they just don't have time to pay attention, you want something short and to the point. If you are targeting trainees who are just starting, who might benefit from the opportunity to look up literature, if it's possible, I give them a link to a paper that gives them that information. That's about as as detailed as you can. But my experience is, if it's this long, nobody reads it. So you have this long to explain to someone why something is important. And you can say, well, the literature says this, the literature says that. Ultimately, you want to say, this is recommended because it saves lives. You want to give them that kind of, hit them where it matters, which is patient care. That's been my experience. Again, I can't say it's defended by loads of research. It's more my own trial and error. But yeah, great question.
Well, I know we've gone a little bit over. Thank you so much for that wonderful talk,